Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody. Thanks for tuning in for Direct Connection. Our focus tonight is the battle against cancer. Later, we'll go behind the scenes of the new Ken Burns cancer documentary. But first tonight, a look at the role of genetics and the very difficult decisions that are facing an increasing number of people. Joining us are Dr. Emily Bellavance, surgical oncologist at the University of Maryland Greenebaum Cancer Center, and Jessica Rispoli joins, a certified genetic counselor, also at the University of Maryland Greenebaum Cancer Center. Thanks to both of you for being with us.
Thank you for having us.
Thank you.
We want to talk about some preventative surgeries. You can tell me how much of this is a trend, but it's certainly in the news because Angelina Jolie, the actress, who a couple of years ago had her breasts removed in the absence of breast cancer, but because of genetic information about her and her family, now she's had her ovaries and fallopian tubes removed. I know it's hard to talk about a case that's not yours, but what do you think is going on here?
Well, she has a genetic mutation that puts her at very high risk for developing breast cancer and ovarian cancer in the future. And it's very important to talk to patients who have a known mutation that can put them at increased risk about all of their options, which include preventative surgery. And your risk differs according to which type of mutation you have, but it would be safe to say that she probably had about a 60 to 80% risk of developing breast cancer and up to a 40% risk of developing ovarian cancer. And I know the last time we were here, we talked a lot about her decision to undergo mastectomy. And this time she has gone ahead and undergone the oophorectomy, which has been shown to increase survival in these patients, and actually it can also decrease your risk of developing breast cancer in the future, the oophorectomy.
In your practice counseling people, these are difficult decisions. I mean, it sounds like I'll just do away with that suspect part of the body, but there are consequences.
Absolutely. So that is an important part of the counseling when we're speaking with women, even before they undergo genetic testing, to give them an idea of, in the event that they do test positive for a gene mutation, that these are some of the decisions that they would be facing. That way, if they do find themselves in that situation, they might have already given some thought, or at least knew that that was part of the deal with genetic testing.
Now, who should have genetic testing?
So first thing to really emphasize, especially for people that might be watching, is certainly not all breast cancers are because of a mutation in one of these genes, and not all ovarian cancers are because of mutations in these genes. It's really maybe only about 10% of ovarian cancers are related to a mutation in one of these genes.
So it's a certain number of people who have a very unlucky gene that gives you really significant odds of getting it, but interestingly, they're not 100%.
In terms of the odds of getting cancer, no. It means that increased susceptibility or an increased risk, but those risks are not 100%. So there are people who could carry a gene mutation and never develop cancer. But the problem is that we don't have a way, just by looking at their genetic test, to really know who's going to get cancer and who won't. And so that's where the discussion comes in terms of their options for management based on that.
Where do you think this is all heading in terms of personalized medicine, genetic information that decades ago nobody dreamed we would even have? Are we heading for a time when everybody knows a lot about their personal genome and what might or might not lie ahead for them?
Well, I don't know if that will eventually be the end result, that everybody will want to know their whole genome or should know their whole genome. It's certainly been, it certainly is a hot topic of discussion. Some people have advocated that all women should be tested for this gene. I think right now most clinicians prefer a more selective approach, and the reason is because when you every time you give information of this type, you need to consider what the consequences will be. So I think that the BRCA genes have been very well studied, and we're able, I think, to reasonably counsel patients on their options, but there are other genes out there that may have an uncertain significance. And we don't want people to be making drastic decisions with limited information. So I would say that's pretty controversial whether or not we should be
I think we're seeing more and more genetic tests come onto the market, but we always try to proceed with caution with that sort of thing, meaning just because a genetic test is available doesn't mean that there's clinical utility or any type of useful information that would necessarily come out of it. But the cost of tests are coming down, so I think there is a lot of speculation in terms of where we might be in another 10 years or 15 years in terms of people getting more extensive genetic tests and using that to make decisions, but I don't think we're quite there yet.
Let me remind our viewers, if you have a question about the genetics of cancer, please give us a call. We'll have the number up on the screen. You could also tweet a question. Our Twitter address is @MPTNews. What is the cost, and does insurance typically cover that?
So to get both genes analyzed, BRCA1 and BRCA2, which are the most common inherited breast and ovarian cancer genes, the cost does run somewhere around $3,000 to $4,000. So it's not a cheap test by any means. Many insurance companies will cover it, not necessarily for all people. In most circumstances, the insurance company likes to see that there's a family history that supports the possibility that there could be a gene mutation. If someone has been diagnosed with cancer at a young age, that oftentimes will make that person eligible to be tested through their insurance.
Let's take a phone call. This is Marsha in Baltimore City. Marsha, thank you for calling. Go ahead.
Yes, thank you for taking my call.
Sure.
My question is, I'm actually a 62-year-old in remission from stage 3 cancer, colorectal cancer. I have a strong history of cancer on both sides of my family, but my question is, my daughter, whose fraternal grandmother died very early of breast cancer, would she be someone that you would consider a strong candidate to be tested for breast cancer or ovarian cancer? And I'll take my answer off the line, and I appreciate your call.
Yeah, thank you so much. Great question.
Thank you.
Good luck.
Thank you. Thank you.
So I have a couple thoughts for that situation. Certainly when we're assessing someone's genetic risk for cancer, we want to take a look at both sides of the family. So I'm glad that the caller mentioned both her history and her side of the family, and then also her daughter's paternal side as well. Oftentimes when we're talking about genetic testing, we like to start the testing with someone that's had a diagnosis of cancer to best understand what could be causing the cancer on that side of the family. So your caller at this point in time might be a better candidate to consider genetic testing than her daughter, at least to start, and then based on her test results, then start to tackle the dad's side of the family as well. So I think the first step is speaking with your physicians to look for what we call these red flags, that there could be something hereditary going on, and then, based on that conversation with the physician, hopefully get referred for genetic counseling for a more thorough evaluation.
Is there a genetic red flag for colorectal cancer?
There can be. We apply the same sorts of red flags to breast and ovarian cancer as we do for colon cancer. So if we're seeing multiple generations of people diagnosed with the same sort of cancer, that's a red flag. If we're also seeing individuals diagnosed with cancer before the age of 50, that's another clue that there could be something genetic going on.
And then if you had that information, I'm wondering about the decision-making process once the red flags are there. So if you're worried about colorectal cancer, somebody can get regular colonoscopies. In cases where breast cancer or ovarian might be in the cards, the screening for that isn't quite as definitive maybe as a colonoscopy?
So the screening for breast cancer, we have good screening methods for patients who are at high risk. It includes mammograms and MRIs.
And not just mammogram, but adding on the MRI.
If you are at reach a certain percentage risk, which you would with a genetic mutation. With ovarian cancer, unfortunately, we do not have a good screening method for patients who are at high risk for ovarian cancer, and that's one of the reasons we can see a survival benefit when we perform the prophylactic surgery. For patients who choose not to undergo surgery who want to wait, which is common to wait until you're finished your childbearing years, we do some imaging and blood tests, but it's really because there's a lack of an alternative, not because we've really shown that it helps. So that's a very important part of our discussing surgery with patients in ovarian cancer, is that we don't have a lot of good screening methods for that.
Baltimore County, let's talk to Mary. Mary, thank you for the call. Go ahead.
Hi, thanks for taking my call.
You bet.
Of course, not knowing all the details, I've been curious as to why Ms. Jolie did not remove all of her reproductive organs, going perhaps in the future that maybe she could develop cancer in her uterus or her cervix. Thank you.
Great question. Thank you.
The BRCA gene has not been associated with uterine cancer, which is probably why she did not have her uterus removed. Some patients do have, that their uterus removed when they get a prophylactic orophorectomy, but it's usually for other reasons. They might be having some symptoms of another benign condition, and so it's all done at once. But for this particular gene, uterine or cervical cancer, neither of those have been shown to be associated with the BRCA gene.
Right, so that's really not even part of the standard recommendation that it's necessary to have the uterus removed in the context of a BRCA 1 or 2.
Okay, let's take a phone call from Baltimore City. Melissa on the line. Melissa, thanks for the call. Go ahead.
Hi. Unfortunately, I have a long family history. My grandmother, mother, and sister all died from ovarian cancer. I've had the genetic testing in my late 20s. I do not have the gene. I'm concerned that there really aren't any early onset tests. The only thing I can do every year, which I have done since I was 28, is have an ovarian sonogram. And I just would love to see something out there that would be beneficial for early detection. And even though my grandmother had had a complete hysterectomy, she ended up dying because it grew in her perineum.
Melissa, thank you so much for the phone call. Any advice?
I can't tell you.
It sounds like the standard of care she's getting, which is the annual sonogram.
Correct.
But it's
correct.
not perfect.
So the average, correct, it's not perfect. We can't really tell for sure if somebody, or at what age somebody who's high risk will develop cancer, even if they will. The average age for ovarian cancer in patients with a known genetic mutation is about 50. So currently the recommendations, they're always personalized for childbearing decisions, would be around anywhere in the 35 to 40 range is kind of the ballpark that is generally recommended.
Is it possible, hypothetically, if somebody was in that situation, incredible, strong family history of ovarian cancer, no genetic marker, decides in that age range to just don't want to take the chance, want to have the surgery, even incurring the the early onset of menopause, would an insurance company pay for it?
So my understanding is that her relatives who have had the cancer could not be tested for genetic mutations. So there's no way of knowing if clearly something clearly something hereditary is going on, but just because she's tested negative doesn't mean she's out of the woods, because we don't know if they had an identifiable genetic mutation or not. They could have just had something that we haven't identified yet.
Right. Right. So maybe it just wasn't passed on to her, and that would be the best case scenario if there was something identifiable and it wasn't passed on to her, or maybe, as Dr. Bellavance is saying, it's a totally different gene. We know that BRCA1 and BRCA2 don't account for all families that have a hereditary form of ovarian cancer. So depending even on how long ago the caller was tested, there might be even some updates to the testing that could potentially provide some answers and maybe give her some more guidance on how she could be managing her risk.
Let's go out to Alexandria, Virginia. This is Mary. Mary, thanks for the call. Go ahead.
Hi, thanks for taking the call. I'd like to ask the panelists about Foundation One chemosensitivity testing, their thoughts on its value. Thank you.
Thank you so much. You're aware of that?
Yes, I mean, I think in our practice we tend to use it in patients who may have been refractory to other systemic treatments, meaning their disease.
It didn't work.
Exactly. Their disease has progressed, and we're looking to try to find more investigational agents to use currently in our breast practice. That's how we use it. I'm not sure how commonly other practices are using it. It's still new, and I think people are still figuring out how it'll be most beneficial.
And that's looking at the genetic profile of the actual tumor, and what Ms. Jolie's situation and the other parts of our conversation is more focused on those inherited types of mutations, not necessarily mutations that just occur in the tumor. So a lot of people ask, is this genetic testing that I'm having? And technically it is, but it's not the more traditional kind of genetic testing that we're focusing on tonight.
As you mentioned, we had this similar conversation a couple of years ago. Has anything changed in terms of the testing you can do that you routinely do?
So I don't know if we're up to the level of saying that it's more routinely done, but just in the past year or so, there have been tests coming onto the market that are looking at other genes that can cause inherited forms of breast and ovarian cancer in families other than BRCA1 and BRCA2. So in genetics, we're slowly moving away from this field of more a gene-by-gene approach, and we're having conversations with families about having a whole panel of genetic testing done at once to look at a dozen genes at once, 25 genes at once. And so that's been a major shift in terms of how we counsel patients and families.
We have to leave it there. Jessica Rispoli-Jones and Dr. Emily Bellavance of the University of Maryland Medical Center, thanks for coming by.
Thank you
for having us.
Good to see you. Coming up tonight at 9 on MPT, part 1 of the 3-part Ken Burns special, Cancer, the Emperor of All Maladies. Parts 2 and 3 air tomorrow and Wednesday night, also at 9 o'clock. Earlier, we spoke with WETA President and CEO Sharon Rockefeller about her battle with cancer and her role in the Ken Burns production. And joining us now is Sharon Rockefeller, the president and CEO of WETA and one of the driving forces behind the Ken Burns series, Cancer, the Emperor of All Maladies. Ms. Rockefeller, thank you for being with us.
Well, thank you for the invitation. It's a pleasure to be here with you.
Glad you could be with us. And maybe start by telling us how this program came to be. Talk a little about your involvement, if you would.
I certainly would. I'm a cancer survivor. I was diagnosed with stage 3B advanced cancer in July of 2005. I went to Hopkins for all of my treatment, and that included radiation, chemotherapy, and surgery. Obviously, I've been back many, many times since then, and I'm also serving on the Johns Hopkins Medicine Board. Hopkins features very strongly in this documentary, and for all the local Baltimoreans, I'm sure you want to see your hospital featured as really the primary and best cancer care hospital in the United States. In 2010, Dr. Siddhartha Mukherjee wrote a book called The Emperor of All Maladies, a biography of cancer. I read the reviews. I was back in Hopkins for a surgery, and I started the book as soon as it got out, and I was finished 3 days straight. 3 days and nights I read it while I was in the hospital. The nurses were complaining I was supposed to be resting. I said, well, everything's resting about me but my brain. I was totally enthralled with the book. It combines scientific research, patient stories, the history of the disease, so we get a context, and then what the possibilities and opportunities are and for a hopeful future. So it's a very unique event. We put together a team for example, a business model which included Stand Up to Cancer, an advocacy group of the entertainment industry foundation. We put together our alliances with PBS and the Corporation for the Public Broadcasting so that 178 public television stations will be airing it on March 30th, 31st, and April 1st from 9 to 11. You know, it will also be airing on NPR. That's the first time there's been a radio piece that accompanies the television series. And so we're very proud of that.
You know, the news flow on cancer is this discovery, that discovery, frequently out of Hopkins. This might be a contributing factor to this disease. What I'm getting at is it's very disjointed. What is the value in this project taking sort of a global view of cancer? Well, it's not so much a global view as vignettes, which we're brought very closely into patients' lives, doctors' lives sometimes, children who are patients. So it's not a big broad brush as much as we spell out that cancer is a very complicated disease. It's not just one kind of cancer. There are maybe thousands of kinds of cancer. So it depends on how early your case is diagnosed, how severe the cancer is, what your chance of actually surviving is. And mine was called an advanced cancer, stage 3B. My internist in Washington had missed it entirely for 16 months. I'd go in with very specific complaints and symptoms. I had a lot of pain and a lot of bleeding, and I knew it wasn't normal. But he kept saying, oh, well, these things tend to go away. So I went back once a month for 16 months till finally I couldn't take the pain anymore. I just couldn't stand it. I couldn't stand, I couldn't sit, I couldn't lie down. Nothing was making it be alleviated. So he said, all right, I'll send you for a Botox shot to reduce the pain. And I went to a surgeon that he recommended, and the surgeon lay down, got an exam, lasted all of about 30 seconds, and he said, stand up and get dressed and come into my office. I did that, and he said, just point blank, you have a very advanced cancer. You must get it treated immediately. You've just worked your last day. And all of a sudden, I realized, at least I was comforted by the fact that there was a reason for what had been happening. I was disappointed in myself for not looking for another doctor sooner, which is what I should have done. But I think this film very much wants to explain to patients, their families, people who are concerned about cancer, what they are supposed to do and when they're supposed to do it if they feel that they have some symptoms. So prevention is always a good strategy in cancer. Try to make sure you don't get it. Stop doing things like smoking or sitting out in the sun. I used to love to sit in the sun, and I did it until I was 35 years old. And now I just stopped cold turkey. And I know that this was a wise thing to do, and everyone has told me so. But some you can't prevent, some you can't help, but some can also be treated by nutrition, better lifestyles, and above all, not smoking. Very good. Sharon Rockefeller is the president and CEO of WETA. We do appreciate your time. Thank you. Thank you. Also, this week on MPT on Wednesday night, your chance to ask a medical expert.
This is what's happening in cancer today.
I'm living with cancer.
In those first few months, I felt incredibly isolated.
Local research, support, stories, and answers to your questions. Fighting Cancer, Questions and Answers.
That program airs from 8 to 9 o'clock. We will have a panel of experts in our studio. You can send questions ahead of time to any of the social media sites listed on the screen. Finally, tonight, we note the passing of a Baltimore civic leader who was a major supporter of MPT and many other organizations. Carol Seibel was a force of nature in the fundraising world and a good friend to many here at MPT. Once described as a one-person united way in a magazine profile, she drove the success of countless fundraising events and campaigns. Carol Seibel was 79. For all of us at MPT, thank you for watching Direct Connection. Have a good night.
This program was made by MPT to serve all of our diverse communities.